right, and the floor is yours. You may be muted, Rachel.
All right, can you hear me okay? I think I got everything settled here.
Yes, we can hear you perfectly. Thank you.
All right. So I was asked today to kind of review the medications that we have for treatment of hepatitis C. So I'm just kind of going to go over everything here for the most common genotypes that we see here in the U.S. and in West Virginia specifically. You can go ahead to the next slide for the objectives. So I'm just going to review those primarily for genotypes 1, 2, and 3, just kind of review how they are formulated, how they come packaged for the patients, and then the dosing administration for those. Going to also review a little bit about the mechanisms of action with some visuals because you guys know I like pictures. Okay, the next slide. So I really like this graphic because it goes over a lot with where we've come, and we've come a long way with the medications that we have available for treatment of hepatitis C. So early on, when we first started with treatments, if you guys recall, we had the interferon and ribavirin regimens in the late 90s and early 2000s. And it was kind of a long time before we saw any development in the more tolerable direct-acting antivirals that we have now. So in 2013 was when we saw the approval of Zepatrim, which was branded as Alisio, and sofosbuvir as a single agent, which was branded as Sovaldi. So that was kind of a big game changer for us in hepatitis C, so that we had more tolerable medications with really good SVR rates compared to the traditional interferon and ribavirins that we had. And from there, we had a lot in the pipeline where we were having more and more direct-acting antivirals that were being approved. So then we got the co-formulated tablet with Harvoni, which was a big deal because, like I said, Zepatrim and Sovaldi were standalone agents. So those were 2 separate tablets. So 2 different copays made by 2 different manufacturers. So there was 2 different copay assistance programs. So it was a lot of work just getting those approved and then affordable to the patients. So Harvoni came out and it was a 1-tablet co-formulated tablet. And then we saw Kyra, Epclusa, Zepatrim, and then from there, most recently, Maverick and Vosevi. And this slide is really nice because it has both the information with the approvals for adults, that's the stuff on the lower side with blue, in the blue, and then the yellow on the top part is what's been approved to use in pediatric patients. So this paper that this was published in was actually published in 2018, so it's not currently up to date with what we have now. I'm going to talk a little bit since we don't really do a lot of, and in this group, we don't talk a lot about pediatrics, but I do have a little bit of the information for the stuff that is newly available and approved for treatment in peds. Next slide. And then this picture I really like because it goes over a little bit of the mechanism of action and what we expect with the new direct-acting antivirals. So the top is the HCV genome, and then you can see the polyprotein and what we get from that genome and how that ties back to the drugs and their mechanisms of action. So the dark purple that's on the left side of the screen, those are the structural proteins, and then the lighter purple in the middle, those proteins are the non-structural proteins. So when we talk about whether this is an NS5A or NS3, that's what the NS stands for. So they're not part of the, the capsule or the envelope, but this is the actual functional part in helping with the replication process of the virus. So that's where our medications are working, as these non-structural proteins. So the first over here on the left are the NS3-4A protease inhibitors. And then based on that name, you guys know that those are going to cleave the polyprotein. So we're going to get this translated polyprotein that's not functional. Normally the virus is going to have a protease that comes in, cleaves all that so that they can fold and mature and actually function. So this is going to prevent that from happening. And the nice thing with the nomenclature here too is that these are all named based on their mechanism of action. So it's easy to remember what's in what class. So all the protease and inhibitors end in the Previr. So the PR for, remember, with the protease. And the next group is the NS5A inhibitors. And what those are, the NS5A is actually part of the replication complex that helps with the RNA replication. So this is preventing that the regulation of the replication so we don't get more virus generated. and all those are going to end in the ASVIR, and that's for the NS5A. So tie that A back to the ASVIR, and you can see those drugs listed there. And then the last section here is the NS5B, that's the polymerase. So these drugs are working directly to inhibit the polymerase from replicating the virus. And those ones all end in the BUVIR, so the B is there for the NS5B. So that just gives you an overview of the nomenclature and their mechanisms of action. Next slide. All right, so let's get into the treatment part. So if in a perfect world there was no insurance dictating what you could prescribe, this is everything that is currently on the market and FDA approved to treat genotype 1 patients. We'll get into these a little bit more specifically, but you can see you've got several options here for your genotype 1 patients. And the asterisk that I have here indicates that this is that these medications are the ones that are preferred on the preferred drug list for West Virginia Medicaid. So we've got Zepatrim, Epclusa, and Maverick for these genotype 1 patients with Medicaid. I have a question mark besides Zepatrim. We've not requested it for a long time, so I'm not exactly sure how Medicaid is handling it. It is on the preferred drug list, but when you actually look at their algorithm that they have for selecting a regimen, Zepatrim is not actually included in that. So it is on the preferred drug list, so theoretically you would be able to get it approved with no issue. But they just don't have it in their treatment algorithm, but it is still on the preferred list. And then the last one is the Vicura, which is on the market, but is not really recommended in the guidelines anymore, but would still be an option for patients if you needed it as well. Okay, so next slide, and we'll start with the genotypes 2 and 3. So with these ones, the PanGenotypic regimens that we have are the ones we usually use for these, and that's the Epclusa and the Maverick. Both of these are on the preferred drug list and in the algorithm for West Virginia Medicaid for these patients. So these are the ones that you would be able to use. Next slide. And we'll start talking now here with, on the next slide, with Harvoni specifically. As the first drug, pretty familiar with this one, guys. I think we're using this one frequently or have been in the past. This one is a combination tablet, like I mentioned before, of ledipasvir and sofosbuvir, and it is one tablet that the patient's going to take daily. So we have two different durations of treatments that we see most commonly, and that's the 8-week treatment and the 12-week treatment. A little bit of background about the 8-week treatment. So during the studies for this, they were in the ION trials, they were looking at 8 weeks versus 12 weeks of Harvoni. And they did notice that they did have some higher failure rates with the 8 weeks of treatment. So they did a post-hoc analysis. So the study wasn't initially powered to look at this, but they looked at the differences, the people that achieved SVR that were cured versus the people that had a failure of therapy. And what they found is that the patients that were cirrhotic and the patients that had a viral load greater than 6 million, those were the ones that were failing the 8-week treatment. So they kind of established these criteria that in order to be treated, you had to be non-cirrhotic and you had to have a viral load less than 6 million. And they did not do the shorter course in HIV patients. So those are the criteria that are established by the guidelines originally. Those are also the current criteria in order to be treated with the 8-week regimen. Now, they're also post-marketing, when this was out, they were following this data, and they did notice that it seemed like Black patients were not achieving SVR with this shorter duration. So there also was that criteria in the guidelines for a good time where it was not recommended to use the 8-week duration in Black patients. However, more recently, there have been some studies that were completed. One was Kaiser Permanente, the other one was the Maryland VA, where they compared SVR rates for their Black patients for 8-week duration versus 12-week and actually found no difference in achieving SVR. So the guidelines have reviewed that, and they actually did lift that part of the criteria. So now you could use the 8-week shorter duration. It is recommended you can use that in your Black patients. They also recently, at the end of 2019, Harvoni was given approval for pediatric patients. Regardless of what dose you're using, all pediatric patients, it's recommended to treat for 12 weeks. I mean, you can see that they have weight-based dosing here, and one of the really neat, exciting things is they have a new formulation of pellets. So they kind of, you can see the bottle that I have up here with the pills. They're pretty good-sized pills for these. So when you're talking, I couldn't get my 3-year-old to swallow a pill like that if I tried. So they did make these in these pellets. They look like little sugar packets, and you can sprinkle those on food for the kids. So there's that option for difficulty swallowing. The nice thing with Harvoni too, originally when it came out, it did not have recommendations for use in patients with renal impairment. Once your creatinine clearance was below 30, it was recommended to not use it, and that's because of the sofosbuvir component that is renally eliminated. It's actually, sofosbuvir is a prodrug, so the active metabolite accumulates in those patients with renal impairment. But they've done several studies since then and actually just got FDA approval to remove any requirements or contraindications in the renal impairment population, because although the sofosbuvir does still accumulate, it seems to be pretty benign. So it's okay to go ahead and continue to use that if you would need it in those patients. And there's also no limitation for any sort of hepatic impairment. So technically could use Harvoni in both compensated and decompensated cirrhotic patients. Okay, next slide. Another exciting development with the Harvoni is that the FDA has also approved the Authorized Generic. So for a terminology standpoint, an Authorized Generic is a little bit different than a traditional generic. And basically what it comes down to is that the company that's making this is actually basically a subsidiary of Gilead that makes Harvoni. So this is coming off the conveyor belts, and in one bottle it's going into Harvoni, and the other is going into a box that's labeled with the sofosbuvir ladipasvir generic name. It's the same drug. So you don't have to worry about the AB rating and is it okay to substitute, that kind of stuff that you do with traditional generics that are made by other companies, because this is the exact same drug. So we do have this available, and I have the cost difference up here just to see. It's about 1/3 of the price of the brand Harvoni. So what this boils down to is this has been a really good change for us for our Medicare patients, because they often have a percentage of the cost of the drug that they have to pay. And remember, with Medicare, you cannot use copay cards from the manufacturer, but you can use foundation assistance for those patients. So what we've done is when they have a percentage, 10% of, $31,000 versus $12,000, we can use the foundation assistance for that copay and still get them treated with this drug. So they're essentially still getting the brand name drug at a lower price tag. So we've used this a lot of times in our Medicare patients where the insurance doesn't care whether we use brand or generic, but we can pass that savings on to the patient. And it does come packaged a little bit differently. Rather than being in a bottle, it comes in those blister packs. And so far from patients, I've heard positives from that because they know exactly how much they have on hand. So when I call them and I'm doing pill counts and seeing if they've missed any doses, they can say, oh, I'm on my second card on the second week. So I know exactly how much they have, and they can use that to help keep track as well. So it's been really nice to have those available. Next slide. Next, with Zepatrim here, this one is also a combination tablet that's once daily. It's got elbasvir and grizoprevir in it, so it's got the NS5A and the protease inhibitor combination. So it has a couple of durations. The most common is the 12 weeks, but in order to use that, you have to make sure that you do the resistance testing, and there's no NS5A resistance to the elbasvir. So that's with your genotype 1A patients. And the 12 weeks you can use for genotype 1B as well with no resistance testing that you need to do. The caveat being the 16 weeks, so they do recommend extending it if you do find resistance with Zepatrim in the 1A population. So when that happens, you do have to do the extension and possibly give that with the ribavirin. I've got the substitutions here for the resistance on here. The guidelines actually don't recommend that you do this. They recommend just changing and using a different agent, which I think most people kind of think is probably better than adding on different drug and having additional treatment for longer rather than just going with the standard 12-week treatment. And this one, its real niche market when it was approved was that it originally came out, it's not renally eliminated, so there was no renal adjustment. So that was back before we had the clearance to continue to use Harvoni. So that was really kind of its place in therapy. We were using this originally for renal impairment patients. The difference though with this one is that because it contains a protease inhibitor, we cannot use it in patients that have decompensated cirrhosis, so that's your child Q, B, and Cs. Remember that the protease inhibitors tend to have this pesky problem where they can tip patients into liver failure for some reason, so it's not recommended any regimen with a protease inhibitor to use in decompensated patients, so this one falls into that category. And you can see there on the right how it's packaged. They also made this one in compliance packaging, which patients do like. It comes in 2 different cards, so 2 weeks at a time. And you can see how it starts. It basically has a Monday through Friday 2-week schedule where you can follow the arrows, and then the patients can keep track of where they are in therapy. So this is another one where we can do pill counts, and the patients easily know whether they've missed doses or not because they can use that to keep track. And you can see the cost difference here that the Zepatrim is significantly cheaper than the other ones for the 28-day supply at a time. Unfortunately, though, with Zepatrim, we don't have any PEDS indications for this one. So this one is for your adult patients only. Okay, next slide. Kyra Pack is the one I said that it's not really recommended in the guidelines anymore. It is still currently available. Some of you may remember there used to be another formulation of this called Kyra XR, where they actually tried to formulate it so that it had fewer, a little bit less of a pill burden, but that one's actually no longer on the market any longer. So we have the Kyra Pack, and it's a combination of several medications, the Umbidisphere, the Paritaprevir, which is boosted with ritonavir, and then the Disabuvir. The ritonavir is only as a boosting agent, has no activity against the hepatitis specifically. A little bit more complex regimen, and that's why they packaged it in this box the way that they did to try to help with that. It's actually 2 tablets in the morning, and then 1 tablet that you take in the morning and the evening. They both have to be taken with food. That's why they tried to color code it over here, you can see. So it comes similar to, I think Dr. Peters coined the Advent calendar for hepatitis C. We talked about it before, but it's made by the same company as Maverick, so it is packaged very similarly, where you get 4 weeks in a box. And then each weekly box has that orange peel off on the front where they peel that off and they can pull out their daily dose. So with this one, the daily dose cards are orange for the morning regimen, and then the second Disabuvir tablet in the evening is blue. The problem with this one is that they do need to make sure they keep the wallet card so they can do their evening doses. So in this one, the regimen is 12 weeks. There's not a shorter duration for this one. This one also is in that area where it's not renally eliminated, so we didn't have to worry about that up front. A lot more drug interactions with this one because more medications in one tablet, you're going to be at risk for that. But remember that this one also has that Previr, the Paritaprevir, so there's a protease inhibitor in it, so we can't use it for patients that have decompensated cirrhosis again. I can't remember, honestly, the last time that we have dispensed this. And I think probably, Kaylee, it was one of your patients where the insurance mandated it, and I want to say that was like last year sometime. But it is still available on the market, but like I said earlier, it's not really recommended in the guidelines anymore just because of the complexity of it. Next slide. We'll move into start talking to the PanGenotypic regimens for our patients that have genotype 2 and 3. These are the ones here that are available. I have the Vosevi on here for completeness, but remember that one's really more for like salvage therapy for patients that have been previously treated. So I'm not going to go about that one in detail, but all 3 of these are actually on the preferred drug list or the regimens for hepatitis C from West Virginia Medicaid. So these are all options for us to use for patients. Next slide. So first I'm going to talk about Epclusa. It's another combination tablet. That's the Velpatasvir combined with the Sofosbuvir. So you've got your NS5A inhibitor and your NS5B. This one's also 1 tablet daily for 12 weeks. Occasionally, you might need to add ribavirin on here. The two instances where you would do that is if you have a genotype 3 patient who's cirrhotic. I didn't add that on the slide, but remember it's for cirrhotic patients with genotype 3 that do have resistance, that Y93 substitution. Want to make sure you're testing those patients, because if that's the case and you're using Epclusa, you are recommended to add the ribavirin. You might actually do it too if the patient has been previously treated before. But this one does not currently have the availability of a shorter duration. It's standard 12 weeks. You can see it's packaged in a bottle. I have the picture here with the tablet. Again, it's a good sized tablet. Right now, it does have a pediatric indication for ages 6 and older, or if the patient is at least 17 kilos. And again, the pediatric regimens are all 12 weeks regardless, and you can see the weight-based dosing there. I got a feeling from the rep when I talked to them when this came out that they will probably also make this one in pellets and go for an indication of 3 and above, similar to what they have for Harvoni. But right now, this just got, I think, in March, just approved for pediatric patients. And again, similar to Harvoni, no adjustment with the renal impairment. Again, the sofosbuvir is the culprit there, and they found that to be pretty benign. And there's no protease inhibitor here, so you can use it in your patients that are decompensated with hepatic impairment. Next slide. This one also has the authorized generic, so same situation as we saw with Harvoni, only you can see the price difference there, and again, it's about 1/3 the price. So we can use this one again for like Medicare patients, try to save them a little bit of money with these expensive regimens. Next slide. So last here, I've got the Maverick. So this one is Dr. Peters' advent calendar for hepatitis C. It is the co-formulated glecaprevir and pibrentosphere. And this one's a little bit different because there are 3 tablets that the patient takes. They take them all at once, 1 time a day. That's a good counseling point for patients, that this is not separated into 3 times daily because the dose is not enough. The tablets all contain the same thing. It's just the actual dose is 300 of the glecaprevir and 120 of the pibrentosphere, so they have to take them all together. Most we're familiar with, I'm sorry, I want to make sure it is something you have to take with food. So patients do have to take this with some sort of food on their stomach. And we're pretty familiar with the 8-week treatment. This is probably one of the more common. They do have something in the guidelines that you should consider taking this for 12 weeks in HIV positive patients with cirrhosis, but that's not something that's necessarily in the package insert. But we also can extend this treatment to 16 weeks in our treatment experienced patients, primarily if they've been treated with direct-acting antivirals before. So this is your combination with the protease inhibitor and the NS5A inhibitor. There is also pediatric dosing with this one for your kids that are age 12 or if they're greater than 45 kilos. And the duration and the dosing is the exact same as adults in this situation. But again, these are good sized pills, and these ones are 3 pills that they're going to take once a day. So that's a consideration if you would use it in a pediatric patient that has trouble swallowing. This one does not have any renal elimination, so you don't have to worry about that with your patients with renal impairment, including dialysis patients. But again, remember, it's got that protease inhibitor, so we're not going to use this in our patients that have decompensated cirrhosis. And you can see the cost there in comparison to the others, the $13,000 for the 28-day supply. Okay, and the next slide. The next slide here is just a summary of everything, all the regimens here that we've talked about, and then the specific genotypes they covered. So I was focusing mostly on genotypes 1, 2, and 3 because that's what we're going to see here in the U.S. and in West Virginia most commonly. But you can see all the different genotypes that they cover there, more inclusive, as well as with the Vosevi, because remember that one is for salvage therapy, but it is pangenotypic because it's basically Epclusa 2.0. With an extra protease inhibitor in there, the voxilaprevir. Okay, and the last slide is just some resources, the guidelines, and then the West Virginia Medicaid criteria if you guys want to have the links to those to look at that. But other than that, that's everything that I had, so I'm happy to take questions.
Awesome. Thank you so much, Rachel. That was great. And I'll be sure to put your PowerPoint in the recap email so everyone can have that link at the end there too. So we got a chat in saying that was a great presentation. Thank you. So any questions, comments, thoughts for Rachel? Feel free to unmute yourselves, or if you're having audio issues, chat them in as well. Okay, thank you so much, Rachel. That was excellent. So if we do get any questions after the fact, I'll make sure to have them sent over to you. So we do have Dr. Rexroad on for your case. I know you're very busy today, so if we only get through one case, that's totally fine. We can do the second one next time, but I'll pull up your case, and anytime you're ready, I will turn things over to you.
Okay, I'm so in the habit of muting that it's hard to unmute. This is a 71-year-old woman who came to us as a new patient less than a year ago. And she's she's retired from cleaning houses, doing office work, that sort of thing. We found her Hep C because she had mildly elevated liver tests and really couldn't find an explanation for it with her medications or anything. So it's a little iffy as to when she might have gotten this. She has not had any risk factors that we can identify. When we found the Hep C, then we looked about A and B, and she's not immune to B. And in talking to her, she may have had Hep A because she used to travel a lot in Mexico, had gotten sick a couple times, that sort of thing. She's had imaging of her liver for other reasons and has not found anything specific. She's really a fairly healthy lady, not on a huge list of medications or anything like that. The vitamin D we started after we did her Hep C workup. As you can see, she is overweight, obese actually, with a BMI of 37.5. So if you want to keep scrolling then to her lab results, white count's not elevated, absolute neutrophils. Hemoglobin is low, and we're in the process of trying to figure that out. We can't figure out whether she's losing blood. She has been anemic apparently all along. But as I say, we've only known her for a few months, so I don't know if this is more or less than she usually is. Sugar was also a little bit elevated, which is probably something new that we're also working on. But her liver-related labs really don't look that bad. Her Child-Turco-Pugh score came out as A. MELD score of 7, her bilia is normal, direct bilia is normal. AST and ALT have gone back pretty much to normal. They were mildly elevated for a while. So I guess keep scrolling. And her vitamin D was low. We've started replacing that. She's a genotype 1A with the viral load of 5 million. Almost 600, actually almost 6 million. So I guess we just like to, she is very interested in getting treatment. She appears to have no risk factors for reinfection at this point. So yeah, we would like to figure out what to do for her. I was kind of excited to see that for Medicare patients, there is the availability now of the generics. So probably I would like to use one of those if possible.
Excellent. Thank you, Dr. Rexroad. Any thoughts or comments about that case? I'll open it up to everyone there. Any recommendations?
I'm not sure if I mentioned, we did start her hepatitis B. We gave her the first shot last week, so so we're starting on that.
Are we unmuted?
I'm unmuted. Great.
Thanks, Dr. Rexroad. Thank you for presenting a case today. it's interesting, she's 71 and just got diagnosed. This is Kaylee, by the way, but you know, I mean, oh, sorry, I don't know if you guys can hear me. I didn't realize I wasn't by the mic.
We can hear you just fine.
Better.
I mean, you really have a variety of treatment options, and Rachel, you know, just went through those. So if you have anything that you kind of want to throw out there after listening to Rachel's talk, that's fine. You know, Harvoni, Epclusa, Maverick, any one of those I think would be reasonable for her. 12 weeks is what I would recommend with Harvoni though, or the generic, just because her viral load's so close to that 6 million mark. You know, kind of just to play devil's advocate, I mean, she doesn't have any evidence of fibrosis. She's in her 70s. I understand, you know, if she's excited to do treatment, and I don't think it would cause her any harm, but truly my approach may be, you know, she's gone this long without any clear risk factors and doesn't have any evidence of fibrosis. And, you know, you can calculate the APRI and the FIB4 as well. Just because she had CT imaging a while ago, that's not usually as sensitive for kind of liver-specific masses. So since that was a couple years ago, you might want to grab an ultrasound on her just as another modality. But by all measures, through calculations, fibro test, I don't have any reason to believe there's anything underlying as far as advanced liver disease. You know, I mean, my approach would be if she wants it, okay, but it's probably not going to do her any harm to just monitor it, because it hasn't done her any harm this far. She's made it this far in life without any fibrosis. She's in her 70s. You know, she was 50 maybe, but I'd kind of give her that option. Give anything else to add?
Quite honestly, it may depend on what the cost to her would be, whether she decides to do it or not.
Right. Yeah.
Yeah, I mean, Kaylee's speaking of the natural history stuff. She's at 1/3 that never has any problems. Hey, the other thing, yeah, I found this fascinating that she reports her risk factor for Hep C is going to Mexico. I don't know what that means.
Because she can't think of anything else.
But we don't talk about, and I noticed her hepatitis A had natural infection, and she's from Arizona. And what I wanted to kind of show, and I don't know if it'll show up, so I don't know. Does that work? Look at that! Look at that IT fix. Isn't that cool? That's some seriously advanced IT. So the punchline was, back in the day, the hotbeds for hepatitis A was the desert Southwest. It's just, if you look at the first interventions for vaccination programs for hepatitis A, we know in 2000, whatever this is, we vaccinate everyone when they're young, etc. And then, but the first risk factor-based vaccinations had to do with geography and ethnicity. And it was really like the desert Southwest and up into Alaska, interestingly enough, sort of the Native American population and also the desert Southwest group. So I just thought it was fascinating. She had natural infection back in, probably given her age, in the 80s and early 90s when that was the hotbed of Hep A. Now we know that you know, the desert Southwest has nothing on Kentucky, West Virginia, and Ohio. We can Hep A with the best of them. But yeah, interesting. But yeah, as far as I know, going to Mexico, unless it's like going to Vegas and it just means what you don't disclose all your risk factors that you might have engaged in when you go to Mexico. But I don't know. Probably not where the Hep C came from. But
Probably not, but she really, you know, I've had a couple conversations with the lady, and I feel like she's being honest with me. I think she really doesn't know. I mean, but in that age group, she may not. You know, we talk about that all the time too. That's why we test all these people.
well said, yeah. She could have got this from some random medical encounter, blood drive, or blah blah blah. Who knows? So
Yeah, if I can't identify really a clear risk factor, I mean, you know, ask about traumas, you know, in the 80s or even early 90s or before, or even dental work as a child, procedures, health issues as a child, hospitalizations, because, you know, before we really were using universal precautions, who knows what we were putting a patient at risk for. So again, you know, at the end of the day, does that matter now? Not really. We have those implemented now, but it just kind of helps give patients maybe some answers as far as how they could have acquired this as well. Although it's not pleasant to hear you might have gotten this from the healthcare field, but but it could be an explanation.
Yeah. Well, one of my other patients in her 70s that I've treated, I mean, she clearly did get it from a healthcare setting. So it happens.
Yeah.
I'm 100% on with what Kaylee said too. This is, 5.9 is too close to 6 million for my comfort level for Harvoni 8 weeks. So if you wanted an 8-week therapy, I'd probably do Maverick, but or 12 weeks of Harvoni or Epclusa, either one. But pertinent case for given Rachel's presentation today. So
yeah, it was great.
yeah, she answered the questions before we could.
Yeah.
That's excellent. Thanks, guys. We got a chat in from Dr. Peters saying she might need a second viral load in 6 months before her insurance will pay for the meds. Thanks for that.
Is Medicare doing that to you, Greg? Or is it Medicaid that does that mostly?
No, I have, like, when I take people's history, so the reason I said that was because just she's never been diagnosed before. I guess time 0 starts with whenever you actually drew her labs. That tends to be mostly Medicaid, but I've actually had really good success with people that come in. They say, yeah, I was told 6 years ago. If I just put in the history that the patient has carried the diagnosis for several years and then a viral load, I can get away with just one. Did you check an A1C? You probably did, but did you check an A1C for her? Do you remember?
Haven't yet. Yes.
It
was 5.9.
Yeah. What's kind of interesting is even in people that don't have that aren't in the diabetic range necessarily, for whatever, I don't know what clinical significance it has, if any, but their A1Cs tend to go to, I've seen that with diabetic patients a lot, but even non-diabetic patients, with an A1C of 5.9, it might go down to 5.5 after you treat her, which is kind of, I've seen that before. I've always thought that was kind of interesting, but it's good that you check that.
Yeah.
I have a question that may be too esoteric to even entertain, but just for the sake of thinking about it, it's so interesting to me, Kaylee, that this idea that, she's 71 and she doesn't have any advanced disease, so an option is to not treat her. One thought I had is, if in the future she were to, at some point she'll probably get something. So if she were to get, and I'm thinking of some kind of cancer that might require a chemotherapy, if she were to get that, would the fact that she has the hepatitis C, would something like that put her at risk of worsening the hepatitis C or having some insult to the liver? And is that an argument for treating her? And that's pretty esoteric given that it's trying to predict the future based on nothing. But I just, she's 71. She lives long enough, she might get something. And a cancer to me would be something that might require a treatment that could have impact on liver.
Yeah, Jennifer, I don't think that's esoteric at all. I think it's great point you bring up. In general, if she did require chemotherapy, Hep C does not flare like Hep B. So, but really, the reason the guidelines say to treat everybody is not always just from liver health, it's also extra hepatic stuff. And honestly, and what we were doing is more entertaining natural history fun, but we would want to, in general, treat her to prevent, like Greg mentioned, keeping her A1C under check. Lord knows when she may develop lymphoma. So what we're assessing is her hepatic health, and her hepatic health seems fine. And so would not represent motivation to treat for hepatic health, but certainly all the extra hepatic stuff. And who knows, maybe that 70, what is she, 71? Maybe she'll feel like a 51-year-old after we treat her. Or maybe she'll just feel better, you know what I mean? So there's all these other reasons to treat people, the global health improvement and quality of life and happiness and aches and pains and decreased glycemic dysregulation and decreased risk of lymphomas and you know, all the other extrahepatic whatnot. So yeah, you're right on. In general, I would not worry about things flaring too much with cancer from a Hep C standpoint. But for all those other reasons, it'd be you'd have to have a very stubborn patient where I couldn't sell them therapy. I would maybe even send them to Dr. Peters, who used to sell cars, and he could he can convince people to take anything. By the way, we've shared a few patients where I've failed gloriously and Greg has had success. So.
Awesome. Thanks, guys. We got a chat in from Tammy thanking you, Dr. Rexroad. It was a really interesting case. So we do have about 15 minutes left of the session. If you have some time, we can jump right into your second case if you'd like, Dr. Rexroad. We can always save it for next time as well. Don't stress about doing that.
I was thinking that maybe we'd save it for the next time and I would actually have the rest of the gentlemen's labs. We have had unbelievable headaches with orders getting lost and quantities not being right, trying to get all this man's labs. So I think I would prefer to present him another day if that's possible.
Absolutely, of course. That sounds perfect to me. All right, so any other last comments, thoughts, questions for the group? As always, feel free to email me with anything if you guys think of things. But if there is nothing else left, then I don't want to hold you guys for another 15 minutes. I do just have two brief announcements. So unfortunately, I'm sure as many of you know now, Caitlin is no longer with us. We miss her dearly. She's taken a different position with WV Medicine. So we missed her a lot. And our other announcement is just that our next session is going to be on July 23rd, and Kaylee Berner is providing our didactic on refresher on PrEP. So keep an eye out for the reminder for that, and we will see you all next time. Thanks, guys.